Okay, so you have triaged your patient, you have reviewed the prenatal record, you've done the interview. Now, what further physical exam do you need to do? Well, you're going to continue to do vital signs on this patient. You need to do a head to toe assessment, just a general head to toe. I have taken care of pregnant patients with broken bones, with ruptured spleens, with the flu. So don't forget about the rest of that patient just because we have a uterus that's actually contracting, okay? As part of the OB assessment, though, we want to try to determine the position of the fetus. And we have something really technical called Leopold's maneuvers that your book will go through. But the idea is to figure out what position is that fetus in. So we want to try to find a rounded, smoother area and then a knobbly side. So if we've got a knobbly side and a smoother side, we can get a pretty good idea which way that baby's facing, right? Because that rounded, firm area is going to be the back, and all the knobs are going to be the limbs, okay? And then we want to feel at the top of that, is it a soft, squishy bottom, or is it a hard head? Because that gives us an idea, is the patient breech or not? So if then their head down or whatever part is down, we want to see if it can be moved. Is it down in, or is it down in the pelvis? Okay. Leopold's maneuvers, I'm not as concerned with you memorizing the exact order of those. What I want you to understand is what is the purpose of those. And it's to get an idea of the position of the fetus. A vaginal exam is usually done. There are some times we would be cautious about vaginal exam. But a vaginal exam is usually going to be done, and we're going to estimate dilation, effacement, and station. Vaginal exam is done by using the second and third fingers on the dominant hand. Make sure that you move the thumb to the right or the left, because when you go in with those fingers, if you have to reach very high, it's easy to accidentally jam your thumb into the clitoris, and that's painful. So we use these two fingers to palpate the cervix, and where the goal is to palpate how far open the cervix is, how thinned it is from around from 0% of face down to 100%. So how thin it is, and where the presenting part is in relation to those ischial spines. Do we always feel those ischial spines? No, it hurts, and it's challenging. So a lot of times we're estimating that. Okay, so dilation, you're going to get a chance to check dilation on Noel. And so what you're doing is you're estimating what the open distance is. We've got this chart. A lot of facilities actually have little cheat sheets for dilation. We used to have them hanging inside one of the cabinets. And so if you were new to labor and delivery, you would go and compare and see, this is how far my fingers were apart. So where are they? So you can get an idea of what you're palpating. Okay. All right. These are supposed to have the membrane still, and then the water's broken. That's what this blue part is. This is supposed to feel like membranes, and then this is the water's broken at this point. So you have one of these charts on each campus that you can look at. In the later ones, you can actually feel fontanelles. If you can feel the fontanelles on the fetus, you can determine what position that baby's in, not just presentation, but actually what position they're in. And that really can help with determining if they need to change positions for delivery, maybe. Okay, so SVE, sterile vaginal exam, is dilation, how far open the cervix is, effacement, so how thinned it is it 75%, 25%, 50%, 75%, 90%, how much of it's left, or how much of it's gone, and then where that presenting part is in relation to the ischial spines. And that station is 0 if it's even. If it's above the ischial spines, it's -1, -2, -3. Below the ischial spines, +1, +2, +3, etc. Okay. When do we do a vaginal exam? Well, we only want to do them with permission and when they're indicated. Vaginal exams are a risk for infection. We're introducing potential infection, especially if the water's broken. And also they're uncomfortable physically, they're uncomfortable mentally or emotionally for a lot of patients. And if you do a whole lot of them, you can cause a lot of soreness and irritation. Typically, we want to get one on admission, of course, because we want to know where they are, what's the baseline. Before we give any medications, especially before we give any pain medications, because if we're giving IV pain meds, we're giving opiates, they're going to have a side effect of respiratory depression. If I give an IV opiate and then the patient delivers in 30 minutes, I may have a baby that I have to Narcan. So we want to check before we administer meds. We want to check if there's any significant changes. The contraction pattern looks different. The mom starts acting differently. There's a change in the fetal heart rate. Any significant changes, we're like, what's happening? Is there a change in the cervix, or is something else going on? If the patient says they have pressure or they need to push, sometimes they feel like they need to have a bowel movement. So if they say they need to poop, don't ever take someone to the bathroom to have a bowel movement in labor without checking them. Never. Okay. Never put them on the toilet. If they have any vomiting, I'm going to check them. If their membranes rupture, we're going to check for dilation for progress, but we also want to make sure that the cord is not presenting ahead of the baby. And then if they have any variable decels, and we're going to talk about what a variable decel means later. Okay. When do we not do an exam? If we know that patient has placenta previa or we suspect they have placenta previa. If we don't know where the placenta is and they're bleeding more than you would expect. Normal show, there should be some bloody mucus, but if they're having a lot of bleeding and you don't know where the placenta is, don't put your hand in there. If you have an unknown placental placement and you do an exam and it feels like hamburger, don't take your hand out. Get somebody to hit the call light and call for help, because once you put your fingers in a placenta, when you remove them, you can cause severe bleeding. That's much, much less common than it used to be, because as long as someone's had prenatal care, we usually know where the placenta is now due to ultrasound. When I went to nursing school, it was a lot more common because ultrasound wasn't used as much. If a patient's in preterm labor, we don't want to do a lot of vaginal exams because increasing the risk for infection actually and irritating the cervix actually increases the risk of preterm delivery. But also, we want to know before we discharge a patient that they are not progressing. So if a patient's in preterm labor, in a teaching facility where I worked, nurses just didn't do those exams. We called a resident. Well, at a community hospital, when there's one doctor on call, you can't call them every time. And so you might do an exam, but you're not going to examine them as frequently. The exam would be more to make sure they're not progressing before you send them home. If the water's broken, you also want to be cautious about doing the first exam. If their water's broken and they're not having contractions, you want to make sure you're assessing the fetal monitor. But if you go ahead and do a vaginal exam, then you've kind of started the infection clock. You have about 24 hours to get that baby delivered. Okay, the next section is going to be about fetal monitoring, or the next several sections, and we're going to have to pull up some websites and look at a lot of different things. I'm really excited about this part. I'm also really excited about what we get to do with it in lab. When you're in lab, you're going to get to see some fetal monitoring changes. Okay.